Hi and welcome back. Hope you enjoyed your tea or coffee, whatever you had. And we are back again to begin with the next session for today's conference. This conference would be chaired and paneled by Dr. P.K. Dev, Dr. Shubhra Banerjee, Dr. Raja Roy, and Dr. Ajay Gautam. May I please request all the respected chairpersons and the panelists to join the session? I can already see few of them joining in. Thank you. And may I please request Dr. Arjun Ghosh from UK to present his talk, Cancer, Chemotherapy and Heart Failure Connection, Risk Stratification, Monitoring and Management. And it is my proud privilege to introduce Dr. Arjun Ghosh in front of you all. A person like him actually needs no introduction, but just to mention that Dr. Ghosh is a consultant cardiologist at Barts Heart Center and University College London Hospitals, UK. He helped establishing cardio-oncology services at Barts Heart Center, which is Europe's largest heart center, and at the University College of London Hospital, which is Europe's largest hemato-oncology center. He has a number of international leadership roles at the American College of Cardiology, International Cardio-Oncology Society, and Asian Cardio-Oncology Society, and he was the first joint author of the first National Cardio-Oncology Guidelines in UK. Over to Dr. Arjun Ghosh. May I please request him to present his talk. Thank you. Happy learning.
Okay, thank you so much for the kind invitation to present today. Thank you to the organizers and to Dr. Banerjee in particular. So I'm going to be talking over the next 20 minutes about cardio-oncology, and there's a lot to cover, so let me get started. I'll be talking about what is cardio-oncology, why it matters, heart failure and cancer, how to define cardiotoxicity, causes of left ventricular systolic dysfunction, diastolic dysfunction, as well as prevention and management, and some advanced heart failure therapies. So basically, cardio-oncology is the management of heart disease in cancer patients, and most of this is due to toxicity from cancer treatment. However, we know that there's a lot of common risk factors between cancers as well as cardiovascular disease, and there are a number of common disease pathways at cellular and molecular level. This is a nice cartoon just illustrating the common risk factors that we can see both from the risk side as well as from the prevention side. So this shows the increasing number of survivors of cancer, which of course is good news. 18 million cancer survivors, and this is projected to increase further. The problem is a lot of these cancer survivors will develop cardiotoxicity, cardiac disease, either during treatment or after treatment. So before, the treatment issues with cancer were quite limited to just chemotherapy and radiotherapy. And as you can see, lots of different issues: heart failure, ischemia, coronary artery disease, arrhythmias. This has moved quite rapidly, the field, faster than cardiology. There are new drugs, many drugs coming out on a basically monthly basis in oncology. And as you can see, there are two new heart failure related toxicities that we can now see with checkpoint inhibitors and CAR T-cell therapy, and I'll come on to this. So one of the problems that we have is defining what is cardiotoxicity. And left ventricular systolic dysfunction, this is a heart failure conference, so I'll focus on that. As you can see on the left-hand side, left ventricular systolic dysfunction, many of the common drugs used in cancer causes left ventricular systolic dysfunction. The European Society of Cardiology came out with recent guidelines, and these include the definition of left ventricular systolic dysfunction in relation to cardiac cancer treatment. So you have symptomatic cancer treatment related cardiac dysfunction, and you have asymptomatic cancer treatment related dysfunction, and you have mild, moderate, severe. In the interest of time, I'm not going to go into detail, but the ESC guidelines came out 2 years ago. They are quite relevant to this. Also, radiation can cause heart failure, radiation-induced heart disease. That can cause valve disease, which can then lead to heart disease. It can also lead to some coronary artery stenosis, some fibrosis that can lead to valve disease. So a lot of different issues ultimately that can lead to heart failure from radiation therapy as well. As I mentioned briefly, some of the newer agents can cause cardiotoxicity. So checkpoint inhibitors now becoming the go-to treatment for lung cancer, renal cancer, melanoma. This causes cardiotoxicity in many patients and can lead to heart failure as well. Similar to CAR T-cell cardiotoxicity, this is chimeric antigen T-cell receptor therapy. This is given in a lot of hematological cancers and is now also being given to some solid tumor cancers. And as you can see, this can also cause left ventricular systolic dysfunction, although it may be more reversible than checkpoint inhibitor cardiotoxicity. And one of the problems, as we kind of briefly discussed, is about how we define what is left ventricular systolic dysfunction in terms of cardiotoxicity. Different guidelines from different organizations, National Cancer Institute, Canadian Cardiovascular Society, European Society of Medical Oncology. So this was a problem that the field had at the beginning. How do we define this cardiotoxicity? FDA, in the interest of time, I'll skip through this. But the FDA, they gave lots of different definitions depending upon the drug used. Herceptin definition, anthracycline definition, different drugs, different definitions. So we decided in the UK to produce our own guidelines, and these are quite similar to the European guidelines. And this is how we define cardiotoxicity, a decline by more than 10% point to less than 50%. And we also include global longitudinal strain in the definition as well. So this is a heart failure cardio-oncology talk. So there are probably 4 key questions when we look at it from the angle of heart failure. What is the incidence of cancer among patients who already have heart failure? If you have incident cancer, does that then affect the prognosis of heart failure? And what about the other way around? Can oncological therapies be given safely to patients with heart failure who develop cancer? And finally, what about heart failure therapy treatment? Does that change after a diagnosis of cancer, especially if you have advanced cancer? So let's see if we can answer some of these questions. Now, the incidence of cancer in somebody who already has heart failure is maybe 19 to 33 per 1,000 person years in retrospective analysis. There's a higher risk of malignancy in patients who have heart failure compared to those who don't have heart failure. Now, is this truly an increased incidence, or is this maybe because heart failure patients are being followed up in heart failure clinics so the diagnosis of cancer is made earlier? Difficult to say. There are risk factors, as we've talked about, and even having heart failure, it causes an inflammatory state in the body. Does this then cause a problem in relation to development of cancer? Some of the treatments, angiotensin receptor blockers, digoxin, are they carcinogenic? There's conflicting evidence in this regard, but we know that heart failure treatments do improve prognosis, make people live longer. Older patients are more prone to cancer. So maybe indirectly there is a relationship. We also know that in renal cancer, patients on ACE inhibitors have better progression-free survival. So lots of ways in which they may be protective and may not be protective in terms of heart failure medications. Now, what are the problems if you have to manage heart failure and cancer and they exist together? When you have a patient with heart failure, you try to simplify the treatment, you try to focus on the cancer treatment. They may not be eligible for an ICD. There was a talk recently, in this conference on CRT therapy, CRTD, CRTP. Maybe the patients will not be eligible if their lifespan is less than 1 year. They may not be eligible for an LVAD. They may not be eligible for heart transplantation. And the other flip side is that a lot of these patients have sepsis, low blood pressure. They may not tolerate beta blockers. They may not tolerate Entresto, dapagliflozin, whatever agent you want to give. So the mortality in these combined group of patients is unfortunately higher as a result. In a recent analysis of 1.75 million patients in Scotland, more than 50,000 patients had heart failure, and the 5-year survival was worse for men with prostate cancer or for women with breast cancer. And epidemiological data indicate that patients with heart failure who have cancer after that have a higher all-cause mortality compared to those patients who have heart failure but no malignancy, or those patients who have cancer but no heart failure. So having both heart failure and cancer, the prognosis is worse. Cancer also independently increases the risk of heart failure readmission, similar to other comorbidities like kidney disease or diabetes would increase the risk of readmission. And again, just focusing on the drugs that can cause cardiac dysfunction and heart failure, these are all common drugs. Anthracycline still used in a lot of hematological cancers, HER2 therapy used in breast cancer. You've got mitotic inhibitors used in GI cancers, cyclophosphamide, bortezomib, carfilzomib proteasome inhibitors used in myeloma and other hematological cancers, tyrosine kinase inhibitors used in hematological and some solid tumor cancers. So these are very, very common drugs. All can cause cardiac dysfunction and heart failure. And it's important to note that the cause of the LV dysfunction does matter. Heart failure due to chemo has a worse prognosis compared to heart failure due to ischemic cardiomyopathy or idiopathic cardiomyopathy. And heart failure symptoms can be secondary to, of course, ischemia, arrhythmia, valvular heart disease, and not just due to myocyte toxicity. So as mentioned, all of those different all of those different cancer drugs can cause a variety of cardiotoxicities, which may ultimately manifest in heart failure. It doesn't always have to be direct left ventricular systolic dysfunction due to myocyte damage. Diastolic dysfunction, again, can be a problem in cancer treatment, and this is recommended for monitoring in guidelines. It may precede systolic dysfunction, but the diastolic parameters are not consistent in predicting chemotherapy-related cardiotoxicity. But there's a number of different ways in which you can get heart failure with preserved ejection fraction, from anthracyclines, from radiation, from checkpoint inhibitors, proteasome inhibitors. So all the drugs can cause some degree of diastolic dysfunction. Maybe that's before they cause systolic dysfunction. It's unclear, but they can cause it. In terms of breast cancer, again, lifestyle and cardiovascular risk factors are, relevant in terms of the heart failure subtypes. So this was a nice study from Garner Anderson's group, and they looked at the Women's Health Initiative participants, and these had invasive cancer, and they were followed up to determine the incidence of heart failure. And what they found was that heart failure with preserved ejection fraction was commoner than heart failure with reduced ejection fraction. And the longer since the diagnosis of breast cancer, the more likely the incidence of developing heart failure, which, we would expect with age. Now, it's difficult to try and work out who's at increased risk. And this is a document from the American Society of Clinical Oncology. And what they talk about is high dose of anthracycline, high dose of radiation therapy, traditional cardiovascular risk factors, older patients, if they have pre-existing cardiac dysfunction, and if there's close treatment between anthracyclines and Herceptin. But there are no kind of estimates of risk for some of the newer medications, such as kinase inhibitors. And this is where European Society of Cardiology and the European Heart Failure Association came together to try and look at some of these newer drugs. And this is really a very nice first figure in that guideline, just showing how cancer patients present to cardio-oncology clinics, to cardiologists, and how there can be problems. So the first patient is somebody who's never had cancer, has never had a cardiac problem, and they need an assessment from the cardiac side. Second patient is somebody who has already had a cancer and treatment, and then has a second cancer which may cause problems from the treatment side, then they need assessment. Third patient is somebody with pre-existing cardiovascular disease who then develops cancer, they need assessment. The fourth patient is somebody with the first cancer who then developed cardiotoxicity and now unfortunately has got a second cancer. They need an assessment. And the last patient is somebody with cardiovascular disease who then develops cancer and gets cardiotoxicity and now has got a second cancer and will be exposed to treatment that can cause cardiotoxicity. All of these patients are very common in every cardio-oncology clinic that I run, and they need slightly different management approach. In terms of the risk assessment from the European Society of Cardiology, the traditional risk factors, lifestyle, cardiac biomarkers, previous cardiotoxic treatment, and previous cardiovascular disease. Now, what do you do with this risk assessment? In that risk assessment, you have an ECG, you do a physical assessment, you also look at things like the troponin and the NT-proBNP, you look at the ejection fraction, you look at the GLS, and try and understand, what is the level of risk and what needs to be done. Depending upon the level of risk, you can also assess the patient according to the therapy that they're being given. So anthracyclines, their risk can be high. With HER2 therapies, the risk can be high. And depending upon the degree of risk and the treatment that they're being given from the cancer side, they require different investigations, different drugs. Now, what do you do with those results? So low-risk patient, probably they don't require anything. They only require cardiology referral after that if they develop cardiotoxicity. And as shown in the previous slide, we've decided how we're going to monitor these patients with sequential echo and biomarkers. If they're moderate risk, they require closer oncology follow-up and a cardiology referral. If they're high risk, again, they require close follow-up from the cardiology service. We can look at troponin, and in the interest of time, I'll kind of skip over this, but troponin has a role to play, and NT-proBNP also has a role to play. I'll skip over this in the interest of time. Now, of course, prevention is better than cure. There's ways to make the diagnosis, as I've shown you, but we want to prevent this. And changing the way the cancer treatment is given, dexrazoxane, different cardioprotective medications can decrease the risk of heart failure in these patients. This study, the Overcome study, a lot of hematological cancers, patients were given ramipril, they were given beta blockers beforehand, and the joint use of ACE inhibitors and beta blockers decreased the risk of developing a fall in ejection fraction. This was a hematological cancer set, and they also, these patients were more likely to be able to complete their cancer treatment as well. And this is a study by Geeta Gulati and her group in Scandinavia, where they looked at breast cancer patients, and what they found was candesartan was protective in terms of ejection fraction fall, and metoprolol was protective in terms of diastolic dysfunction in breast cancer patients. Now, what about advanced heart failure? Once the patient develops heart failure, the treatment of the heart failure is with heart failure guidelines, and you go for quadruple therapy with ARNI, beta blockers, MRA, SGLT2 inhibitors discussed. ICD, CRTD can be considered if the life expectancy is more than 1 year. That's the practice in the UK. We can also consider mechanical circulatory support, heart transplant, if the life expectancy is more than 2 years and the cancer has been treated. And if they have got ongoing cancer, that normally is a contraindication to heart transplant. And data from, registry data from the transplant different registries has suggested that there's an increasing use of LVADs as well as heart transplant in cancer survivors. So physicians are becoming more aggressive in the management of patients who, survived cancer. However, you can also, and in the UNOS database, 453 transplants were given for cardiac cancer-related cardiotoxicity. So even cardiotoxicity is now becoming actually a reason for heart transplant, and these patients obviously have cured cancer, and a number of different other data. However, there are risks of bleeding, but similar risks of infection and device malfunction in these patients. Now, mantle radiation is a contraindication to heart transplant. So mantle radiation is commonly used in lymphoma and a number of hematological cancers. And the reason this is a contraindication is because the wound does not heal in the sternum after, bypass or any other kind of cardiac surgery. There is an increased risk of malignancy with immunosuppression used after cardiac transplantation, which is important to be aware of. And in this study in JACC Cardio-Oncology, you can see the increased risk of malignancy after heart transplantation. And a lot of this is due to immunosuppression by sirolimus and other agents. And in terms of, I think the timer is coming up, so I'll just finish off. In terms of the management of patients, number of different issues in terms of combining the problems with both heart failure and cancer. And in the interest of time, I'll skip this. lot of data in terms of late complications of cancer, late effects, and heart failure in these patients. So coming, I think, now to the end, late effects, patient has been cured of cancer, patient are being monitored now for problems. They should be monitored every 5 years if they are at moderate risk. If they're at high risk, maybe monitored at 1 or 2 yearly intervals. And again, last bit of my talk, development of cancer in patients with heart failure, systemic inflammation. I touched upon this earlier. There's an inflammatory milieu that can maybe cause heart failure, can also cause recurrence of cancer as well together. So in conclusion, lots of common pathways which link heart failure and many cancers. Prognosis is worse when both coexist. The presence of either can affect the management of both. There are problems in defining left ventricular systolic dysfunction in the context of cancer treatment. When should we use cardioprotection? When should we intervene in subclinical cardiotoxicity? And probably the best management of these patients is within the remit of a cardio-oncology service and a cardio-oncology multidisciplinary team assessment, and lots of different resources that are available. I'd like to acknowledge my clinical and research teams. Thank you very much.
So thank you, Dr. Ghosh, for this insightful talk on a very difficult subject, which is quite difficult to understand. As you know, unfortunately, in our country, cardio-oncology as a subspecialty hasn't really developed, but I'm sure in near future it's going to do that. So let me start the discussion with a couple of questions. So from my side, the first question I think is my colleague, Dr. Raja Roy and Dr. Ajay Gautam, as panelists. So the first question that I would like to ask you is, like, in patients with heart failure with the reduced ejection fraction, most often, even if the LV function improves, we do not stop the medication, except a few cases, situations, for example, maybe in Takotsubo cardiomyopathy or maybe in peripartum cardiomyopathy. So, but here, in case of where the heart failure has developed secondary to cardiac toxicity, and now the patient has stopped the treatment and the LV function has improved, should we stop the medications or should we continue?
I think that's a very relevant question, and a lot of our patients ask us this question very frequently. Patients not with anthracyclines maybe, but maybe more with Herceptin breast cancer patients, often we see with treatment the function can recover. Patients always ask us in clinic, how long do I have to continue? Can I stop the medications, etc.? Now, we have data from the TREAD-HF study, which came out of the Brompton in London, suggesting that if function recovers and if you stop the medication, in 33% of the patients, a third of the patients, the function will again fall, even if function has recovered. So what we do when the patients ask us this is we say, well, this is a situation, and if you do stop the medication, we will still monitor you. So we often would monitor that patient with an echocardiogram at 6 months, we would monitor that patient with an echocardiogram at 1 year, and then we would maybe push out the monitoring. I think it's a different situation if there was a severe, significant fall in ejection fraction. So if the ejection fraction went to, say, 35%, 36%, something like that, then recovered, in those patients, I think we would hesitate much more in stopping their ongoing heart failure medication.
Thank you. And just a quick follow-up question. Like you did mention, like patients who are in very high risk group, I think you mentioned at times we may start ACE inhibitors or beta blockers as a primary prevention, right? If you do that, then how long would you continue these medications? I mean, would it be indefinitely, or after some time you may stop those medications if the patient doesn't develop?
Yeah, that's a very good question. So normally we wouldn't give maybe primary prevention unless they already had mild or some kind of abnormality. What I mean by that is, if the ejection fraction and the GLS fell during treatment, but they haven't necessarily fallen to more than 10%, and there's a subclinical cardiotoxicity, in these patients, I think we often kind of intervene. We often give, beta blockers, ACE inhibitors at an earlier stage. we would consider stopping that if the function normalizes and maybe, a year after treatment, everything is stable. But we would still monitor the patient for some time. Because this is a new field, we don't have the long-term data to suggest that the patient should be monitored for 2 years or 3 years or 5 years. That we're still trying to understand, we're still trying to learn. There isn't really enough large-scale evidence to say that all patients should be given ACE inhibitors and beta blockers if they have normal cardiac function beforehand. However, we do know from observational data and from small studies that if you do that, much less likely to develop cardiac dysfunction. But that hasn't been translated into a large study with breast cancer or with hematological cancer.
Thank you. Dr. Roy?
Yeah, thanks. Thank you, Dr. Ghosh, for such a beautiful speech on a topic which is not very much talked about topic in this part of the world. Thank you. My question is, like Dr. Subramanian has already asked you, I'm talking about a patient, who has got who is suffering from chronic heart failure with ejection fraction, say around 32%, and who develops some sort of cancer, whatever, maybe lady with the breast cancer. So would you opt for the standard anthracycline or the heart therapy, or would you like to give a second line drug, safer drug, considering, her, the cardiac condition situation?
So I think, again, that's a very relevant question, interesting question. I think if you look at the prognosis from severe heart failure, which this patient has, maybe it's worse than actually the cancer that they then develop if their ejection fraction is 32%. In that situation, probably the oncologists themselves would be very hesitant to give anthracyclines, HER2. They would want to give less cardiotoxic treatment. I would say that question is maybe an easier question. What's more difficult is if they come in with an ejection fraction of 45%, what do you do in that situation? Because there is data to suggest that if the ejection fraction is between 40 to 50%, the vast majority of these patients can be given their cancer treatment safely if they get ACE inhibitors, if they get beta blockers, and if they're monitored closely by cardiologists. I think once the ejection fraction goes less than 50%, oncologists become nervous. Once the ejection fraction is less than 40%, most oncologists would not agree to give any kind of cardiotoxic treatment. And if that was the only option, you would really have to tell the patient that there's a very high risk of death.
Yeah, so just one question, like say the aim is of course to minimize the interruption of therapy, but the therapy needs to be interrupted in a case, say, where the LV function falls. So when would you restart your anti-cancer treatment? Say that when the LV function recovers, or would you wait for the LV function to recover, or is there any way of knowing it when?
Yeah, so again, that's a very common scenario. It often depends on the drug that's being given. So with, say, anthracyclines, if there's a fall in ejection fraction, difficult to say if there will be recovery, difficult to say when the recovery will be. So we would always kind of give intensive treatment. We would reassess the patient maybe in 1 to 2 months to see if there's a change. We'd look at biomarkers, troponin, BNP, see if things are getting better. We would always consider re-challenge if there's an improvement, and we'd always have the discussion with the oncologist as to are there alternative treatments. As Dr. Roy was mentioning, are there any other options? The easier or maybe different approach is if the patient is a breast cancer patient and the patient's on Herceptin, trastuzumab, because in these patients, often the function does recover and it recovers quite quickly. So if a patient has a fall in ejection fraction with, Herceptin, you stop the Herceptin temporarily, you give them good heart failure therapy, you reassess the heart function within, say, 1 to 2 months, often you will see recovery. And we would normally restart the treatment at that point with the oncologist. If there is a big gap in restarting treatment, then from the oncology side, the prognosis is actually quite bad. So if the gap is limited to maybe 4 to 6 weeks, prognosis can still be okay. And the other thing to remember is from the different oncology trials like HERA and others, you should try for 9 months of therapy. I mean, the ideal is 12 to 18 months of therapy, the cancer therapy. But if you can get the patient to complete 9 months, the prognosis is nearly as good as if you can complete 12 to 18 months of therapy. So that's kind of the approach that we consider in these situations.
The other question from Dr. Roy, Dr. Gautam?
Thank you so much, Dr. Ghosh, for your nice presentation and information. I have a practical question which usually comes to us. See, all these patients on chemotherapy, when they visit to us for first echocardiography, so what are the types of cancer which we should be vigilant about particularly? And second question is, how often or what should be the frequency of echo follow-up?
Yeah. So again, a very relevant practical question. I think one of the take-home messages is nearly every type of cancer treatment can cause cardiotoxicity. As I showed in my slide, there are some treatments that are more likely to cause left ventricular dysfunction, which will be picked up by echo. Now, anthracyclines, commonly used drug, Herceptin, commonly used drug for breast cancer, I would say probably are two of the biggest agents that do need monitoring in the form of echo every 3 months. Those are the kind of guidelines that we wrote. Those are also similar to Indian guidelines. And in terms of echo, again, we would always recommend 3D echo because that can give us the changes earlier in terms of monitoring. And we also always recommend using GLS if possible.
Yeah, right.
Earlier.
Okay, thank you so much. Thank you so much.
Thank you, Dr. Ghosh. I think really we are very thankful for you to make your time to attend our session. And thank you once again. It's time to wrap up now and move on to the next session. Thank you.
Thank you.